Duilio Pagano from ISMET Palermo is a really friend of us, a very good surgeon, and we'll talk about the impact of laparoscopic resection for access to the waiting list for transplantation entering and dropout flows analysis. So it's a waiting list analysis. Duilio, please, floor is yours.
Hi, thank you for this opportunity. I hope that you can see the presentation in the correct format now. And thank you for this opportunity because I will present here our experience in the impact of laparoscopy resection for access to the waiting list for liver transplantation in a region with a very low rate of donors per million population. As you can see here, we have just the period of time between 2000 to 2022, a very reduced number of donors if we compare it with the Italian rate of donation. So for this reason, we have a preferential point of view in terms of potential impact of liver resection to reduce the entry flow in waiting list for transplantation, because we are only one referral center for end-stage liver disease and the hepatocellular carcinoma in patients with liver cirrhosis in our region, our island in Sicily. And we are the single regional liver transplant center, so we have a direct impact on matching for anthropometric conditions in patients with a risk for liver transplantation, so we can decide the correct time for our patients. And we have adopted since 2026 the ISOSCORE allocation system that was introduced by Professor Cilo and the national government for the liver transplantation in our country. So the pressure waiting list during the period of time between 2016 to 2022 was homogeneous, as you can see here, with a range between 18% to 121 patients between 2006 and 2022. This is our period of time. And in this period of time, we had, as you can see before, the rate of donation for a million person. And the type of liver transplantation was very different, because we had the possibility to treat our patients with living donor liver transplantation in our center, and split liver grafts, and this is a donor liver transplantation. Complete in this type of donors are included also. This is the brain donors, and this is our donors. So since 2006, we have introduced also machine perfusion devices. So you can see here our experience now is increasing day by day, year by year. At the same time, we have changed our approach for downstaging, as was discussed before. So we have introduced it from 2016 with the type of inclusion. So we have decided to include patients with the child patients. So we have decided to treat patients with low count of platelets and with varices. So for this reason, we have followed the literature, and we have decided to expand our indication for liver resection and try to treat them and not with an intention to treat the method. So we have decided to resect this patient with a preferential minimal invasive approach. As you can see here, we have decided to analyze 685 patients, and 443 patients were HCC patients, and the other 242 patients were patients with cirrhosis and stage liver disease that were directly introduced in the waiting list for liver transplantation after a proper evaluation with our transplant hepatologist. And in this study period, we have decided to resect 131 patients who were not eligible for transplantation, a lot of them for comorbidities. And so we had 997 patients that were resected, but they could be defined eligible for transplantation before 2016. Of those, 9 patients underwent early recurrence after resection, and all of them were introduced in waiting list for liver transplantation because this recurrence was only in the liver and they were introduced in liver transplantation with after a proper evaluation. And only 2% of these patients were, or resected and transplantable patients were affected by recurrence. It was extrahepatic, and they were not as well included for liver transplantation waiting list. And all 215 patients, so quite the 50% of these patients were introduced in the waiting list for transplantation. So the number of patients that was introduced in this waiting list were 464. Of these, so we have the similar numbers in terms of HCC patients and the stage liver disease patients. For this reason, we have decided to have two homogeneous group of patients in terms of number. For this reason, we decided to look for the impact of ISO-score allocation system in this patient. Was changed also with the ISO-score 2.0 in 2019. And as you can see here, we have a comparison between what we have decided to define the resected and resected and transplantable, as you can see again the number. And for patients who were resected, only resected with the absence of prohibitive comorbidities, but the comorbidities was the reason why we have not decided to consider them transplantable. The planned laparoscopic computer resection, always we decide to have a zero resection with anatomic resection potentially for our patients. Large HCC patients that were considered minor criteria out, but we have just really expanded our criteria for transplantation, but not for a patient with HCC larger than 10 centimeter. And the importance of the presence of portal hypertension. I will remember that in our institute before 2016, we had the possibility to measure the portal hypertension and the gap, this difference between the systemic pressure. So after this, we have decided to, following the literature, and perform a child evaluation with endoscopy for excluded varices, esophageal varices. As you can see here, as you can see here, we have a number, increased number of resection between 2017 to 2022. And this type of resections are also associated with a major number of laparoscopic procedure. And this is, you can see here, the terms of recurrence between the two groups. So they were quite homogeneous between, we intended for resection, and we are planned for resection, but were theoretically transplantable without the study period. As you can see here, with this, the reason why the characteristics that are associated with type of resection, with type of recurrence after resection, and after multivariate analysis, there are very important in terms of biologic consideration of the tumor as a multifocal HCC and the size of the tumor. Of these patients, we were included only for liver transplantation. 464 patients. We had patients who were dropouted in the similar rate, 36 in the HCC patients, and 79 for end-stage liver disease. And we have increased the year by year also the number of patients who underwent to machine perfusion recovery of the organs between also patients with the liver cirrhosis. For example, for HCC patients, we had an increased number of recovered organs, and this is the cause of that. The outcome of patients that were into the waiting list. So 9% were dead in waiting list in patients with HCC. On the other hand, the patients who were dead in the waiting list for liver cirrhosis were 20%, but it related to the disease, and so we know that this kind of patients can really drop out in a different manner. And for the analysis, we see that there was not a lot of difference between the dropout intention to treat analysis and the competitive risk analysis of these patients in terms of probability of dropout between patients with HCC and patients without HCC. And it is quite similar to the number of the national number that were presented in the past by Silvia Trapani in the national government conference, and the number of patients who were dropped out were quite similar in terms of probability between the two groups. At the same time, we saw that the dropout rate, the patient rate of our patients between HCC and non-HCC patients were quite decreasing year by year, and we decided to compare it with the number of laparoscopic procedures. So we were able probably to reduce the pressure on our waiting list without the entry flow of HCC patients directly for liver transplantation. So I will finish this presentation. Thank you for this and inviting you in our conference that will be performed in Palermo in the 6th to the 8th of October for the National Conference of the Italian Organs Transplantation Society. Thank you.
Thank you, Duilio. Thanks a lot also for the timing. I don't know if Giuliano wants to ask something. My only comment is thanks also for the effort you did in retrieving all the data and putting everything together in order to find a sense and a rationale. We all have this problem how to integrate, our local regional approaches with liver transplantation and vice versa. The only, weakness in this analysis is going to find a group of patients transplantable according to what? Which criteria, and resectable according to which criteria. This is still so subjective. That is the analysis at the end of the day, it becomes a little bit weak for that particular definition. That this is the only comment that I can give. But thank you very much, because this is really a very crucial topic. Giuliano, any comment?
I have a question which is probably quite old. So the resectable, I consider, that you have a child A, normal spleen size, no thrombocytopenia, and below 5 centimeters, and then you do resection. The question is, if you can, would you transplant the patient right away? Or because, the relapse is quite, the risk of relapse is quite high, and you may end up, with relapse which is distributed and which is large, and you cannot transplant the patient anymore. So in a setting, where transplantation is possible, would you say, yes?
Yeah. Thank you for this question. And it is very important that we define our patients, and thank you for the comments of Professor Cillo. We have defined our patients in terms of transplant indication. So if patients have a lot of comorbidities, so we decide to resect them before. But year by year, we decide to perform as a general input to this patient. So we have preferentially indicated liver resection when it was possible, also with an increase in terms of platelets number with drugs, or in terms of support of our patients with liver cirrhosis with a correct balancement of liver disease. So it is very important for us to have a strict synergy with our transplant hepatologists, and we thank them to ameliorate the outcome of our patients. For this reason, liver resection for us is mandatory, and it is the first approach for hepatocellular carcinoma. Just not only for doing this with minimal invasive surgery, and we know this is a sort of protective effect of this disease, but also for having a possibility to reduce the early recurrence after liver transplantation. So it is a first filter for decide what is the better patient with a better outcomes after liver transplantation. Because for us, it's a very real, difficult possibility to have a graft in our region. So now the things are changing with the politics modifications, but we are now decide to have a different impact for HCC patients with a preferential impact with a liver resection. Thank you.